Hey everyone, and welcome. Happy Pride. We are excited today to be watching the NIH report about what the Stillbirth Working Group Council came up with for this year. So I'm going to unmute that. Hopefully you guys can hear it. We are sharing that on the screen here. I'm Samantha Banerjee. I'm here with my colleague and friend, Anna Lebevic. And we'll try to give you guys the background as to what they're talking about and why these things are important as they get revealed. But here we go.
In the United States, the working group presented their recommendations to you back in January of 2023. And now we're going to hear an update from those co-chairs, Dr. Lucky Jane and Dr. Uma Reddy. Lucky Jane is a neonatologist who currently serves as pediatrician in chief and Department of Pediatrics chair at the Children's Healthcare of Atlanta. He's also the George W. Brumley Jr. Professor, chair of the Department of Pediatrics at the Emory School of Medicine, and executive director of the Emory Children's Pediatric Institute,
since I think 10 a.m.
and as I mentioned previously, served as a member of the NICHD Advisory Council, and we miss him.
Meeting going on.
Dr. Uma Reddy, MD, PhD.
And so various groups have been sharing kind of with, I guess, with their colleagues, what they've been working on. And so this is the last section to be shown today. And it's about the Stillbirth Working Group. So they have had, I don't know, what was it, three meetings this year, public, that we were able to watch through the live stream like this. And Dr. Reddy and Dr. Jean here are kind of leading the charge this year. And we're super excited because this year what's new is a prevention council. And so we're really excited to see what they're going to say.
Everyone. So it's a real honor, Dr. Bianchi, to be back here with the NICHD Council. I do miss you all as well. Before we get into the meat of our recommendations, I wanted to, on behalf of Dr. Uma Reddy and myself, thank the entire NICHD staff, particularly Natasha Williams and Monica Longo, for their help in preparing the previous report and the current work that we have accomplished, I feel, in a very efficient manner. So if you all will get to the first slide, Dr. Bianchi has already mentioned that back in 2022, the congressional mandate allowed us to, with the NICHD, establish a task force. $1 million was contributed by the congressional committee to get that workforce started. Next slide, please. And that work focused largely on getting the CDC, the NIH, and outside organizations to work together to focus on 4 primary areas. The first one was current barriers to collecting data on stillbirths throughout the United States. The second.
I'm muting them really quick again. So these bullet points might look familiar to you if you have read at all about the Shine for Autumn Act. So this is one of those federal bills that's in Congress right now, specifically designed to address the data collection issues with stillbirth in the United States. So as that picked up steam in Congress, Congress sent the order to the NIH to say, hey, we need more information about this. Can you make a working group to address it? So they did. Which is fantastic. And but one thing you might notice is that the word prevention is not listed anywhere in that mandate. But don't worry, we took care
of that. Of stillbirths, given that stillbirths still impact a large number of pregnancies in the United States. And when that happens, we heard from people who've gone through this, person after person, how devastating that occurrence is, and how for decades later they continue to live through that horrifying experience. Next slide. In the next few slides, I'll summarize for you what we discovered in the first year of engagement with all of the external agencies, NICHD, and with the task force. Um, the first recommendation related to removing the barriers around collecting data on stillbirth was that we needed procedures to improve the consistency and quality um, of data collection. We needed to standardize case definitions. We needed to train people who are involved in data collection for fetal death certificate, because up until then, that process was very haphazard and not standardized. We needed to improve processes for updating vital records. Um, and then finally, outreach to states and localities to raise awareness around.
So in plain language, you hear a lot from parents in the stillbirth community about how we don't get answers about our stillbirth. And a main issue there is that when we don't get answers, they don't get documented into the data, which means the researchers have a really hard time getting decent data to figure out what's causing stillbirths and how to stop it. Even more frustrating is that when we do get answers, there is no way to go back and update your child's fetal death certificate on an ignorance zoning.
Yeah, definitely. I think this is probably my biggest pet peeve of the whole
Disparate.
we're in. Unfortunately, there is a process. You can do an amendment process, but it has to go through your provider who signed the original cause of death, and that can provide another barrier because, it's leaving it up to the person who gave you the care or who was just the one who filled out the form. So it's really hard to actually do that, and I didn't get to do that with my son. So I'm still working on trying to make that more of an automated situation. I'm hoping that here with this being called out, that will happen.
The last thing I want to point out about last year that's really critical to know is, again, when this group was created, prevention was not part of their mandate. And that was something that was immediately brought to the NIH's attention by several advocacy groups in the parent community. And we kind of were like, oh, well, this is what Congress wants to do. Our hands are tied. And it very quickly became apparent during those first sessions that they were missing the mark. They were talking about how stillbirth is caused by things like obesity and drug use and lack of access to care. But meanwhile, all these parents watching this, 80% of pregnancies take place in otherwise healthy, low-risk pregnancies where there are no known maternal risk factors to start the pregnancy. So yes, there are some obvious known risk factors, but for most pregnancies, they're happening to people like us who had perfect pregnancies until all of a sudden we didn't. And that's what we really needed them to take a look at. And so our community, along with several of our partners and lots of individual parent advocates that work with us, jumped through a bunch of hoops over that fall of 2022. We were coming right off of the big push, our national walk, our March on DC on the National Mall. And, one of the things that we really took to heart was making sure that parents were heard by this NICHD group, because there were, no parents really on the panel. And the things they were looking at were just not what reflected the lived experiences in our community, and particularly did not reflect the lived experiences of Black moms, brown moms, Indigenous moms, and basically anyone from a marginalized background. And those are the groups that are bearing the brunt of the burden. So that was something we worked really hard to make sure that parents and particularly diverse parents got heard. And so they ended up actually adding a fourth session onto this initial working group, which was a listening session where parents each got 2 minutes to share whatever they wanted to say. And I think that was huge in turning the tide. The word prevention again was not mentioned once in this initial working group's mandate. When the report came out, and we'll pop the link to the report if you want to go read it. It's also linked from the media page on our website. the report had the word prevention in it over 90 times. And this year, the reason we're so excited as Push, as an organization pushing for stillbirth prevention and the end of birth in the United States, what we're most excited about is that this year's actually had a prevention committee. So we're really excited to see what is coming out of that.
Research engagement was needed to develop a research agenda, which ultimately could advance prevention of stillbirths. The research agenda would include efforts to identify true implications of stillbirth prevention from the NIH Human Placenta Project and related research that's already being done. Further, we felt that we needed to establish baseline normative data on the physiology of pregnancy, including in particular potential indicators of health and disease. Now, these may include, but they should not be limited to, placental development and function, fetal movement, fetal growth, etc. And finally, when we looked at research risk factors, we realized that the focus on under-investigated areas might yield or might discover new risk factors that we are not aware of right now, particularly in the area of health disparities in stillbirth. And ultimately, stillbirth, having a robust stillbirth registry with good autopsy data would be very helpful in that regard. And ultimately, we would then be able to develop and test indicators and clinical interventions for stillbirth prevention. So a summary of these recommendations essentially is provided in this slide, which is to improve the quality of vital statistics, surveillance, and epidemiologic information at all levels, local, state, and national levels. We need to use insights from improved epidemiologic data to conduct additional research that helps explain and ultimately addresses disparities in stillbirth. We need to conduct implementation research and develop culturally sensitive interventions to support families who experience stillbirth. And then finally, we need to create and support a robust research agenda, which includes both known and unknown risk factors and the physiologic mechanisms that ultimately lead to stillbirth, and that ultimately we would try to modify to prevent stillbirths. So then fast forward now to 2023, Dr. Bianchi mentioned.
So if you're just joining us, I just wanted to share, we just heard a recap of the findings from last year's stillbirth working group from the NIH. And we were really thrilled to see that what came out of that was specific recommendations to look at unknown risk factors, which is a huge issue in stillbirth. The known risk factors only explain about 20% of stillbirths. And also to come up with prevention and with clinical intervention. And this is something that's really key. What we've been told by people with more experience with NIH research than we are is that it's not normal for the NIH to tell people, to tell the community, the research community, you need to do something about this. Normally they say, oh yeah, we need to learn more about this. There's some funding, you guys figure it out. But this working group, because of the hard work of parent advocates in the community, calling out that this, the work that they are doing is critically life-saving and urgent. It needs to happen now. We cannot wait for more research. We need to use the tools that we have available at this time in parallel with doing additional research to improve those tools and come up with new ones going forward. And so this is what they came up with for this year's.
The first one was to continue our work on helping improve data collection. The co-leads of that group were Dr. George Sare and Dr. Mickey Young Shin. The second group focused on stillbirth prevention and strategies. And this was led by Dr. Bob Silver and Dr. Allison Cahill. And the third group was focused on enhancing resources for families impacted by stillbirth. And this group was co-led by Dr. Jill Weber and Dr. Karen Gibbons. The general recommendations from the group, the three groups are listed in the next couple of slides. I won't go through the depth of these slides because that's what Dr. Uma Reddy is going to cover. But just to show you, give you the overall essence of where we're headed with this, that there is a compelling need to standardize data reporting and collection to promote more accurate and consistent surveillance of stillbirths, that there is need for support for population-based surveillance, such as expanding the CDC PRAMS network, also the SOARS survey, to capture diverse voices of those experiencing stillbirths in jurisdictions with high stillbirth burden. We need to explore the role artificial intelligence, machine learning, and newer ways of improving medicine and care delivery can play in improving risk prediction, stratification based on existing data, and ensuring that that sensitive health information can be safeguarded in this process. We need to create tools to educate patients, healthcare professionals on risk factors for stillbirth, and whether these are bundles or other interventions that needs to be looked into carefully. Next slide. We need to create standardized training with proper infrastructure and resources so complete stillbirth workup can be accomplished. We wanted to move away from fragmentation of how this is done so that there is completion of autopsy, placental pathology, and genetic studies, even if it is done in smaller cohorts, which can then provide more wholesome information to guide intervention strategies. We need to create infrastructure for perinatal audits to enable analysis and discussion of stillbirth and further identification of risk factors. And finally, we need to support research on how structural, institutional, and interpersonal racism contributes to the horrible inequalities in stillbirth rates. The offering and completion of stillbirth work group ultimately will improve access to healthcare opportunities, improve quality of care after stillbirth when it is not preventable, and improve bereavement care as well. So really a lot that we have been able to accomplish.
Well, first impressions, that is a phenomenal list of stuff. And there's a lot of new things here this year, which is super exciting. The AI stuff is totally new. That was not mentioned all last year. The specific call out about racism and the role of systemic, structural, and interpersonal racism that plays out in the huge racial disparities we see amongst birth outcomes, particularly with Black moms. That's huge. And the way that they are looking at the data and making sure that it's more robust, also really good. So lots of good stuff here. Excited to hear the details.
Incomplete pathology and histology information that could improve understanding of causes of stillbirth and potential avenues of prevention. Genetic testing is often not done because of the cost and logistical challenges. And perinatal audit, the process of capturing information on the causes of stillbirth and analyzing the quality of care received in a no-blame interdisciplinary setting to guide action to prevent similar deaths in the future, unfortunately is not routinely performed. Next slide. So recommendations from this. Consider conducting research on timing of delivery to develop personalized recommendations on the optimal time for delivery based on risk factors.
Yeah.
Currently, induction delivery may be offered in 39 weeks per the ARRIVE trials study results, which showed in low-risk patients induction at 39 weeks of gestation was associated with benefits such as decreased C-section, lower rates of hypertensive disorders of pregnancy, and no maternal or neonatal harms compared to going beyond 39 weeks. Addressing health disparities and the social determinants of health and their role in stillbirth, supporting population-based stillbirth surveillance, especially in jurisdictions with high stillbirth rates, and providing access to high-quality prenatal care and postpartum care. Next slide. Further recommendations, additional research is needed to develop stillbirth prevention bundles that focus on patient and provider education, including public health measures such as advice to cease tobacco use, helping people achieve a healthier body mass index, optimizing management of chronic medical conditions such as diabetes, hypertension, and others, and induction of labor. Linking of maternal and fetal medical records, consider creating a stillbirth registry and collecting stillbirth biospecimens. Consider universal use of low-dose aspirin according to the United States Preventive Services Task Force guidelines. Next, we'll turn to the improving data collection subgroup. Slide. So their findings. Surveillance and medical definitions, including gestational age and birth weight criteria that currently vary by state. These definitions for stillbirth, pregnancy loss, and miscarriage are not currently standardized. Therefore, data collection is inconsistent. Clinical data collected from multiple sources, electronic health records, monitoring data, imaging studies, genetic testing, pregnancy experience, patient history are not integrated and linked across data sets so that all information is accessible for research and stillbirth prevention. There's a lack of uniform training of individuals completing fetal death certificates, which hinders more accurate record keeping. Currently, fetal death certificates are required to be filed within days of the stillbirth, incorporated into the fetal death certificate, and a formal legal amendment is needed. Therefore, information from the delivery and subsequent testing may be delayed and not integrated into the fetal death certificate, including not into the final cause of death. Next slide. Recommendations include collecting, transforming, integrating, and maintaining electronic health records and other pertinent data sets in a format appropriate for future use in artificial intelligence and machine.
Yeah, one thing that people are often surprised to learn is that stillbirth certificates in many states, and I can tell you New York is definitely one of them, are still recorded on paper. They're not entered into electronic medical records at the time of birth like a live birth would be. And that causes all kinds of issues. And as they mentioned a couple minutes ago, many states don't even have the same definition of stillbirth, and they're not using the same format to upload things. So it's really hard to do anything useful with this data because it's not consistent, it's not in the same format, and most times it's not complete.
Mortality review. Improve and develop quality indicators for evaluation, counseling, bereavement services, and follow-up, and conduct regular audits to improve the quality of data collection. Next slide.
I'm excited about that one with the infant mortality
Further
review.
recommendations on education with the following.
Go through that process with their
Representatives should provide ongoing in-person training to collect fetal death data. Providers should be encouraged to use guidance documents and e-learning tools developed by NCHS. Hospital personnel should be educated on using a flow chart that's been developed by NCHS to understand how to fill out the fetal death certificate, and personnel should receive training to improve the overall fetal death accuracy and completeness and ensure the filing of amendments.
Yeah, again, one thing here that's like really shocking is that, you know, when you have a live birth, there is someone in the hospital who's responsible, right? Like, this is their job. They know how to do the forms and everything. But this stillbirth, that's not true. You get the nurse or the doctor, whoever's on call, they get this form with a million things on it they've never seen before. They have no training on it, and they're just doing their best to fill it in. So
Yeah.
a lot of these things, again, are really common sense, but so desperately needed.
No, and what I've learned when I'm trying to do Owen's amendment process is that unfortunately these have to be done so quickly. Usually they want them filled out within a few days so that then they can get, you know, your baby to wherever you're going with your baby. So I had a funeral, so of course there's that process. So the next step, they have to do their paperwork within a few weeks. So they go by whatever the person, the doctor, whoever filled it out put, and usually they just put unknown cause. And I've been told that, the majority say unknown cause because they haven't gotten back autopsy information. They haven't got, obviously placenta pathology or anything like that back. And they're just seeing, the birth and, oh, well, it looks like everything was fine. The baby looks normal. Like my baby was normal. So they had nothing to write. They just said, well, natural causes. And of course, that helps nobody as far as prevention in the future. So it's not so much that all these babies have no cause of death. It just is improperly placed. And then they don't go back. Like we're saying, we need a really automatic amendment process where it wouldn't go through the parent even, because I have to relive my trauma constantly calling people like, can you help me? Where do I fill out a form? And then, getting the roadblock of the provider saying that the lawyers don't want her to do it. So it's really frustrating for the parents. I don't know anyone else who's really tried this, to be honest. And they told me too, where Owen was buried, that she's never seen one. She's never seen an amendment for a stillbirth or even really any information other than unknown causes, like in all her 7 years working there. So it's important. We need to count what matters. We count what matters. And if we're not counting these fetal deaths, stillbirths, whatever we want to call them, then no one's really paying attention to what's causing them, and we're not working towards solutions of preventing them. So that's why this is so important, that we're now saying we have to fix this. This procedure is just not working as it is.
But emphasize that testing is the best that can be done to determine the cause, and emphasize that the baby will be treated with care and respect. For postpartum care, need to address the physical needs of the person giving birth.
Thank you.
Provide information on recovery from
What's
childbirth,
awareness,
especially for first-time parents. This could include resources and staff that address milk production, physical recovery from childbirth, and postpartum depression. The risk of depression is high in parents who've experienced stillbirth. Providing close postpartum follow-up and mental health support for grief, trauma, and depression is essential. Provide national and local resources for support, creating standards of care for other professionals, such as social workers and chaplains, who might regularly interact with families experiencing stillbirth. And states should consider the availability of stillbirth tax credits similar to live births. So overall recommendations and themes that went across all three of the subgroups. Standardizing data collection and reporting, exploring new technologies such as artificial intelligence and machine learning, creating a stillbirth prevention bundle, creating standardized training so that a standard stillbirth workup, including autopsies, genetics, and appropriate blood tests are performed, conducting perinatal audits after stillbirth so that specific protocols can be developed following stillbirths, research ways into reducing the health disparities in stillbirth, establishing continuing healthcare provider education related to stillbirth, research the most effective mental health support after stillbirth, and making the cost of the stillbirth workup more affordable, including access to autopsy, genetic testing, and placental pathology.
Yeah.
So it's been a privilege, along with Dr. Jane, to co-chair this working group, amazing work of this group on such an important topic. Again, I want to thank the entire NICHD team, Natasha Williams, Monica Longo, Laura Berkson, for keeping the work group on task, being extremely organized.
So I know they've got until 4:30 on the agenda saved, so hopefully that means we'll get some Q&A now here. I'm very curious to see what people are going to ask about.
Contributed their time and expertise, and most importantly, the parents and families who courageously shared their stories and are hoping for improvement in the stillbirth rates in the U.S. Thank you.
We love you already.
And Lucky.
We love you, Uma.
Very important working group. The very detailed recommendations. Thanks to the NICHD staff, as well as the.
If I remember correctly, I think Dr. Jane said that he found out through the process of being part of this that he actually had a stillbirth in his family. It might even have been his sibling that was born still, or some very close relation. It just goes to show how little this is talked about, right? Even amongst a family of doctors.
On the perinatal autopsy, there are barriers to access that will be very difficult to overcome. And I was wondering if in your work you considered the sort of non-invasive imaging-based autopsy that may be sometimes easier to achieve. And then related to that, what's often experienced is that after an autopsy, it takes a long time to get the full report back. And within your recommendations, I did miss it. I didn't see something about a future recontacting of the families for a preconception.
Bravo, I like this lady. She's saying what I want to say. I'm not there. So thank you for saying this.
Thank you.
These are all excellent, excellent comments. And a lot of it is the details of the report. But, your point about, fetal autopsy and how difficult, perinatal autopsy, how difficult it is to get a quality autopsy done because of the lack of expertise. So doing non-invasive methods like a fetal MRI or like that, definitely considered that. And so the recommendation that, we are never going to train enough perinatal, pathologists. So using telehealth, developing regional centers of excellence where these evaluations can take place. So trying to increase the training of qualified people, but as well as, sharing the expertise so it's available across the country and developing these centers of excellence. In terms of these results come back, yes, months later, and families often don't even hear the results. So making sure that they get follow-up about the results and making sure they get incorporated into the fetal death certificate. And it's difficult. You have to do a formal legal amendment. We kept hearing from families that the cause of death was wrong in the fetal death certificate. And they, paying all sorts of money to try to amend it to just get it corrected. And then you had another point in the
Thank you. That's my point.
I think it was related to what you already said, but sort of remote from the occurrence of the stillbirth, have another contact with these families, either when they're planning a future pregnancy or just to provide closure to the whole experience.
Right. So having that visit to go over all the tests and results, and then ongoing mental health support. We heard it over and over again how families felt, abandoned, because that too is very hard to get perinatal psychiatry, perinatal mental health resources.
And to that, add to that, Uma, I think there was much discussion around adding to some sort of autopsy, whether it is anatomic autopsy or imaging in lieu of the autopsy, but coupled with detailed placental pathology and genetic information. They found the body of the information that ultimately can help families figure out whether or not their next pregnancy is at risk. The biggest worry that families go in from one pregnancy to the next pregnancy is having sleepless nights thinking my next baby is also going to die.
Yeah, and families are right to feel that way because they've been shown to be at almost 5 times the risk.
David.
They're stillbirth.
Great comprehensive report, and there's so much to do. I just wanted to maybe comment on the training aspect and probably the reasonable role for AP and ACOG to require bereavement training for instances of stillbirth. And there are now training courses, and there's actually a national course in the NHS. And I do think that would be a great suggestion to make to help our training programs to develop this curricula and provide the tools for junior doctors to support parents going through this ordeal.
Yeah.
That's an important comment. And the fact that it's in this report saying that, training needs to be done. And there is, specialized training for handling families that have suffered a stillbirth and the pregnancy afterwards. There's a Rainbow Clinic, which is a clinic
that's just talking about our training.
Specifically for families that have experienced stillbirth.
So
So adapting that training,
at Columbia,
incorporating it into our
over
curriculum.
100 staff members at
Because,
Columbia
our
taking
residents
coaches,
and
pregnancy after
fellows,
loss training
physicians, they don't get
to
specific
help
training
prepare
on how
them
to
for
handle
opening
this.
their own Rainbow Clinic, which will be number 3 in the country.
Barry and then Cynthia.
Hi, Lucky and Uma. Thank you very much. This is really impressive that both Congress and NICHD wanted to focus to address recommendations. I have two questions. The first is the challenge of not having a standardized definition. And it just depends on which state you're in and how this is defined. Was that part of your recommendation? And if so, did you have a standard definition?
Well, we have a bullet point about it that says the gestational age and birth weight vary across state. And it, for stillbirths, for even miscarriage, pregnancy loss, and the CDC, was a partner in this. So, this I think falls under the CDC. So yes, standardizing that.
Good. And then, the question comes as to who implements these recommendations. Congress has requested them. How do we move forward? And then you mentioned something, Uma, at the end about the importance of who covers the costs.
Yeah, so that's a
Right.
$1 million.
All very good questions. I think, in terms of a lot of the research that was outlined in the first report about the placenta, fetal movement, medical conditions, risk factors, that falls to NIH. A lot of the data collection pieces fall to the CDC. In terms of, funding, I hope there's funding to carry out the recommendations. And the cost of the workup is a real issue for families. It's not covered by insurance, so that's another aspect. And care after having a stillbirth too. A lot of it is not covered.
That's right.
And Sherry, I think it is important to think of this as as an effort that has to include inherently organizations like the CDC, Health and Human Services, CMS, NIH, because there are different aspects to tackling a malady such as stillbirth. So there is a body of research that needs to be done. Even if you come up with a definition as a task force, that needs to be validated, and that needs to be something that all states are willing to adopt. And that's where the CDC comes into play. That may be one way of bringing the states together, but ultimately managed, and that's where it's very hard to control that or manage that, as you know.
That's right. Thank you for your work.
Okay, Cynthia, and then Bonnie.
Hi, Lucky and Uma. Thank you so much for this work. I just wanted to amplify the comment on placental pathology. I think that for pregnant individuals who go through this, they perhaps don't realize that you need very special expertise to be able to look at these placentas, and they get sent, and then the results are not particularly informative. And so I think these stillbirth centers of excellence is going to be really, really important. The other question I had, I think you mentioned, Lucky, that you had an extra $1 million to continue to work for the next year. And so I was just wondering if you have had the chance to think about what your plans are moving forward.
No, Cynthia, that was that money and the congressional assignment funded the work that we just finished. I would recommend that if there's more work to be done, that maybe we'll rope you in, Cynthia. We appreciate your participation in the task force.
Well, we're going to ask Dr. Nahida Chaktora, who is the branch chief of the pregnancy and perinatology branch, to let us know what's happening in terms of research that has come out.
Yeah, so absolutely. Thank you. I think that we've already published a notice of intent to publish. We're not calling them centers of excellence. We're calling them the Stillbirth Consortium, and there will be an opportunity to have more details on it. Hopefully, it'll be published sometime this summer, and we're hoping to take some of the recommendations related to research and expand on them, and so that we can move this field forward.
That's very exciting.
Yes, so we had a sort of a three-pronged strategy for how to address this. We received a small amount of funds initially from the first year to be able to expand on the data component. So we, as you all know, we have two networks that we fund and support through the pregnancy and perinatology branch. So one is the maternal fetal medicine unit network, and the other is the neonatal research network. And what we wanted to do is to have them work together to improve the collection of data that they have. So they're to be able to collect data around stillbirth and preterm birth as well. And so that's the first step with the small amount of money that we received, is to improve, between the two networks, we have over 230,000 deliveries per year between the two networks. So that's a significant number of deliveries and potential to collect data around stillbirth. And so that was the first step. The second step is that we released a notice of special interest around stillbirth, and we've received applications that hopefully should be reviewed in June, later on in June, and we'll see where that goes. And then the third step is the NOFOs, or the consortium still around stillbirth. So those are.
So that's pretty exciting. This is the first I'm hearing about 3 different areas where funding's being available to press this forward.
Yeah. I mean, honestly, as a lost mom listening to this right now, it's frustrating because it's a little bit of the conversation. Where do we get the money from? And do we have money for the work we need to do and to save these lives, And I think what people forget is that stillbirth has a cost. It's not like just a dead baby. Like, it's not just a pregnancy loss that you can move on from, and so. Like, I think that there's still a shift that needs to happen here in these conversations, where we need to realize the long-term impact of the stillbirth, but also the cost involved.
Mm-hmm.
You do have to go through a high-risk care your next pregnancy after loss, if you do proceed with another pregnancy, and there might be issues that reoccur, so you'll need a higher level of care. So if we can avoid some of the stillbirths in the first place, that will actually be cheaper if you're thinking about money here. And it's
Yeah,
a
and
hard
mind, like,
to listen to as a parent. You're like, I would,
like
right.
mental health care, so many costs associated.
Mm-hmm. So hopefully they'll work out the money part, but we'll keep.
I wonder if you've engaged the American Academy of Pediatrics. I think somebody mentioned it earlier, but from the standpoint of engaging with pediatricians and trainees, not necessarily from a research perspective, but maybe from an advocacy perspective, as well as from a training perspective, they might be able to help, along with ACOG, implement some kind of a policy or white paper to recommend to pediatricians and to AMCs that are training individuals how to at least address current approaches, given best practices that we have now, given that there's so much that's not known. We do at least can provide some degree of support for families, and the Academy can be helpful as well in doing advocacy on the Hill, for example, and looking at payment and things that you mentioned. So that's just one issue. And then the second one is, of course, we know that, in the US, this is an issue, but we know that about 2 million, we estimate that there are about 2 million stillbirths every year around the world in varying degrees of sociodemographic conditions. And so really starting to maybe think about partnering with WHO and others around this topic, because if it's difficult in the US, it's almost impossible in other parts of the world. And while we have seen under 5 child mortality drop by 60-75% around the world in the last 30 years, stillbirths, we don't really know the true burden. And that burden, as far as we can measure it, is really static over the last many decades. So really, I know you only have $1 million, but partnering with other organizations such as AAP, for example, right away, and then WHO in some longer term way might be useful as well.
That's a great point, Bonnie. I actually mentioned some of the work that we were then in the middle of doing to the American Academy of Pediatrics Executive Director when I saw him at the AMSPDEC meeting recently. So they're aware, but we will hopefully we'll work with the NICHD to make sure that the report is circulated and socialized with all leading agencies that can help further conversations around this and foundations where some of this work can be enhanced, including foundations such as the Gates Foundation and obviously the World Health Organization.
Yeah,
The
that's what
good
we always
thing,
say. United we push.
and Uma will confirm
Work
this, the
together.
good thing about this phase two,
We'd absolutely
Bonnie, was that
love to see
we
some of
had
the agencies you
several
mentioned. Stillbirth.
leading members of the international community in stillbirth research and implementation science, including people from the Scandinavian countries, England, Australia,
Oh,
New
yeah.
Zealand, places where they have made more progress in stillbirth prevention than perhaps we have been able to. And so some of that will continue through those people in those regions as well. Uma, did you want to add anything to that?
I think, I think AAP is a great idea because we heard the impact on siblings
Yes.
is huge. And
Yes.
so that pediatricians are having to deal with. And then afterwards, with the next pregnancy, and Lucky mentioned it, there's a dread that every time the birthing patient comes in, that there's going to be another stillbirth. I mean, even once, the patient's had a live birth, the family is still traumatized thinking about it. And so I think, involving pediatricians and the training is really important. And then the Global Network and Gates are doing important work on stillbirth, internationally, but, collaborating with them. And, we, as Lucky mentioned, we did collaborate with the stillbirth bundle, that bullet point about, best practices. So we had
talk about that.
leading experts from the UK, the Netherlands, from Australia, discuss their stillbirth bundles. And they have rates of like 2 to 3 per 1,000 versus our 5.7 per 1,000.
And there are groups, Bonnie, like the group in Utah led by Dr. Bob Silver, who have now formed international movements around stillbirth prevention. Many of those people were part of this exercise with us. So your point is really well taken. I think we need to expand the impact of this work globally as well. Thank you.
Okay, is there any further discussion? I know it's been a long day. Sorry. Oh, Genevieve Neal Perry, sorry.
No, I actually had comments about how the family members were being included, just thinking about the impact on the family. The other thing with trainees, particularly OB residents, I can tell you they're pretty traumatized when that happens as well. Yeah. And so it's not just training, it's really around how to, meaning training and how to interface with the patients, but also how to interface with one's own feelings around that death. And that loss. And so I just want to say
that 1 in 10 OBs
important
have
work, and I want to really commend you on the work that you've done, and particularly on the fact that you've highlighted the disparate experiences of different people, because these are real and they have significant impacts on not just the patient but the family. So thank you for that.
Yes.
Yeah.
Oh, sorry. I was just going to say, I haven't heard the word father mentioned. And as when we had a special session of the original working group devoted towards hearing lived experiences from the families, we heard from a number of fathers and how they were profoundly affected. I mean, it was very intense, that whole session. We all needed tissues.
Welcome to our life.
Yeah,
we can say that affects the families, but it really affects the families. So I'm sorry, Lucky, I interrupted you.
No. I wanted to mention.
Watch the recording they're talking about on our YouTube
the
page.
fact that
going across the bottom
participation of the mothers who had lived through this experience was one of the most moving parts of this entire undertaking. And glad you mentioned the dads who were who are not normally noticed in this whole occurrence. But you're absolutely right. The families that are impacted disproportionately are the ones who also don't get appropriate follow-up care or any care beyond that. So thank you.
Yeah, dads, grandparents talked about there's a higher rate of divorce. I mean, it is traumatizing. And Dr. Neil Perry's point about the healthcare professionals. I mean, as a physician, you feel incredible guilt. It's traumatizing when your patient has a stillbirth. So I think, yeah, helping providers deal with, the situation as well, because if they are, if we do proper training, then they'll be more available to families and be able to better deal with the situation for families.
Great. Well, thank you both. Thank you to all the members of the working group. Cynthia served on the working group. Thank you to our staff. And may I have a motion now for approval of the working group's report?
We approve.
Move to approve.
Approve.
Thank you. May I have a second? Second. Thank you.
Okay, you asked, but we will.
So now we're going to vote in person, and Christina and Genevieve will vote remotely.
Honestly, do you think they missed anything? I think it was very thorough. I think
It was really thorough. I mean, and
This
there's
is
lots of
for-
new
you're
stuff in
voting for
there.
approval.
Lots of very explicit call outs of things that
Okay.
are incredibly important. And again, the systemic racism.
Is somebody counting?
The femur, we should explain to people what that is, because I'm sure a lot of viewers don't know.
11?
The bundle,
And
the bundle,
online?
that's super exciting.
So again, we got 13.
training,
So
for
we'll figure out who is
all-
actually able to vote.
The good
So
news
much,
is we have what we
so
need.
much
The
good
bad
thinking
news
out
is
of
we
this.
need to
This
learn
is-
how to
this is
count.
really,
Yes.
really exciting.
Oh, we need to inform people who have not been fully cleared yet that they can't vote. But we'll figure it out. So with that, I know it's been a long day. There's been a lot of information thrown at you. The good news is we're coming to an end. This is concluding the first day of our 2-day advisory council meeting. I want to thank you all in person, virtually, the staff, for participating in today's activities. We look forward to seeing everyone tomorrow. There'll be a brief open session first that will.
Well, that was good. I'm very happy. Thank you for organizing this, Sam. We just decided last minute we should chat about it live while we watch it, because unfortunately, there are some parents in the working group, but not too many of us are invited on these sessions. So we can't share in real time how we feel. And that's kind of hard as a parent, just to sit there listening. And you're like, oh, I want to say this and that. But actually, like, it's night and day from the first sessions, obviously, because when it started, they were off
from the first session.
that we didn't really feel was accurate, and we're just like, no, but we want to, and we were actually in the original Zooms until they realized we might be a little bit too emotionally involved for the session, I guess. But they ended up saying, no, you guys wait to talk, so we'll let you talk, but we need to do all our things, and then we'll let you talk. And then it actually, I think, led to a very, accurate representation of what the situation is, because they did listen to us and they did take that into account in what they were doing next and these next steps.
Yeah, I mean, it's very clear that they absolutely listened, and I have to say it's really meaningful to me as a parent that they really do constantly refer back to that listening session that we push them to have as being a turning point for them. I mean, you heard them say it right there, that it was intense. It was intense. And
we didn't take that lightly. When they said we were going to be able to talk, we made sure we wanted to have all the voices in the community there. Unfortunately, a lot of times certain people aren't invited in, or they don't know about it. So we were just like, we're reaching out to all our partner orgs, everyone. It's not just a push thing. Like the way our #United we push, like we stand by that. We're not about just building up this organization. We want to make sure everyone has a voice in it. And if you have an advocacy group, we lift each other up, because we need every one of us in this work. And you all have different stories. We all had different experiences of our losses and how it happened, but there are some similarities, and I think that does help these researchers and people in these positions to make some really good recommendations. So thank you all who did the sharing. I know it's hard, and a lot of communities, it's not commonly done. It's not something that any of us really want to be doing. I hate sharing Owen 24/7 as like a lost story. I'd rather share that I love him. He's my son. I'll do anything to help save other babies, but it's still very traumatizing.
Yep. Well, thank you, Anna, for all you do. And yes, huge thank you to everyone in the community who's been speaking up about this, and particularly who came to that listening session. I mean, so much work went into, first of all, just members of our team, hundreds of change makers reserved spots to make sure that we can get as many voices as possible heard. And then there was a very organized effort to reach out to others in the community, voices who had not been heard, particularly BIPOC parents, because again, some of those this is the community that's bearing the absolute biggest brunt of this burden. The disparities are huge. And it was something that really had not been touched on through the entire first working group. And so that was something really focused on. And so again, it's really gratifying to see that it has become such a big part of what they're talking about going forwards, because that's absolutely, I mean, that's the low hanging fruit in stillbirth prevention. If we close, I'd like to say simply, but it's certainly not simple, but if we simply close the gap between Black and white stillbirth outcomes, we'd be saving 4,000 lives every year in this country. And that alone is a 17% reduction in our stillbirth rate.
Mm-hmm.
So,
there's so many things in this, but bottom line, we just want to tell our community here how grateful we are for all of you and
making a difference.
Us, and your babies matter, and it's very hard to be a part of these things. I know early on I hated going to all these conferences because I just heard all the ways my baby should have been saved, and all the things that could have been done better, and all the things that they didn't do for Owen. And that's really painful as a parent, to keep reliving the loss over and over and over, and seeing, like no improvement either. It's like they mentioned, this statistic has not changed. And that's very frustrating as a mom, because, the minute your child dies, you're just like, what happened? And okay, nobody knows, no one's helping me. And now what? Okay, I got to spend the rest of my life figuring that out. And then when I figure it out, I'm like, oh, here you go. Here's something so you can help other babies. So I don't want it.
Yeah.
What a slap.
That's the most frustrating part. I think for me, it was watching in the years after Alana's death, first Scotland and the UK and Australia all implementing these bundles that they are finally talking about here, and seeing the rates drop in real time. I mean, you heard what they were saying at the end there. Their stillbirth rates are a third of what ours are. A third. And they started exactly where we were. And so that's the most painful thing, is knowing that something could have been done for our babies and wasn't. And we're standing there saying, my baby died and you need to do better for the next family. And them telling us, nah, like that is unacceptable. And so to see, these public health leaders in our country standing up to say, enough is enough. It's time. We're going to do something. And we're going to, we're talking to our international. I mean, that's so exciting that they're, how many times do we bring studies up to doctors in the US or somebody at ACOG, and they're like, oh, well, that doesn't, that's not in the US. It doesn't matter. It doesn't count. It's not the same. It's like, yes, it does. And so it's so incredible to see they're actually sharing knowledges across nations. And, again, I really think it comes back to our community and the fact that we, that first meeting, we all jumped in there and we were sharing links to studies, links to those bundles, all the statistics, our personal stories, the absolutely horrific stories that we have been told by our friends in the BIPOC community who faced, direct racism in that resulted in their loss. And, I just remember one of the reasons we were so frustrated when they, in the next couple of sessions after that, didn't allow us into the actual Zoom again, was because, I was getting private messages from other healthcare professionals in that Zoom saying, thank you so much for the information and the context you're providing, because I would not be learning nearly as much as I am right now if it wasn't for you and the other parents sharing your stories and sharing these other resources that it doesn't seem like anybody here knows about.
Well, and then that's the reality, is that they're basing it off of US research, which is very limited. We haven't had good data collection
we're
yet,
behind.
so of course they're going to say certain things that we are like, what? That's crazy. We didn't smoke. We didn't do drugs. We're just like pissed off because we're like, you're suggesting these things. So you're actually perpetrating stigma. You're making it
Yes.
worse.
Yes.
Like, you need to stop, because I was a healthy low risk pregnancy. My baby was perfect, all these things. So like, we had to stop it there. And thankfully they realized, well, maybe there's something to this. Maybe we should let them speak. And then, that corrected itself. But the research is bad. It's limited. Let's just say it's not bad, but the data is bad, I would say, because it's based on inaccurate and not updated information. So thankfully they're working on the data, which, we're all pushing for the Shine for Autumn Act right now as well. That's a big one. And Debbie's a part of that council, looks like still. So she'll make sure that that's going to happen. That's a great start. How can we fix something if we don't accurately know? Like, we could tell you, but you're not asking us either. Parents don't get a debriefing like they do in other countries. And I really wish that would be a part of it. Those fetal review committees, all those kind of things. Like, if they do those things, that will really help inform them in the future. Like, give us a chance to speak, share about our pregnancy. What actually do we think happened? Where were we saying something and it didn't get listened to? What symptom did we have that's not reported in this fetal death certificate that's very brief and it's just done quickly by whoever filled it out?
Yeah. No, I mean, I think, yeah, that was really huge. The fact that they're talking about, I don't know if they actually use the term femur, but yeah, we call it, it's called fetal infant mortality review. And there are some states in the US that do this regularly, but not the majority of them. And what happens is basically every time a baby dies in the end of pregnancy, or, shortly after birth, a committee of doctors will sit down and review all the medical files. Someone who is trained to be, sensitive, will actually interview the parent and ask them, like on a set, like what happened from your point of view? Like, did you feel like you weren't being heard at any point? Like, what did you notice? And then they will actually go through and be like, find the failure points, and be like, how can we fix this? And just imagine if we were doing that for every stillbirth in this country. I mean, like, the information that would come out of it would be huge. And the thing that's really exciting for me too is that, one thing we've done really well in the last couple of years is started doing this for maternal deaths, which again, absolutely should be done after every single maternal death. We need to understand what went wrong and how to make sure that never happens again. And, a lot of this stuff is interconnected. It shares a lot of the same roots. And so, there's a lot of infrastructure already in place for maternal mortality, which is fantastic. And I think it would be really simple to just basically piggyback off that. I mean, the CDC Hear Her campaign, one of the maternal warning signs, the urgent maternal warning signs they educate people on, is a change in fetal movements. And I was looking, I think this is a recent update on, I don't know if you saw this. If you look at the details on the fetal movement one, like on the CDC website, it actually says there is no set standard for the number of movements. Every baby is different. You need to get to know your normal. Like,
we had conversations with them. Remember back?
We had many conversations with them, but I hadn't seen them actually update it yet.
Oh, yeah. No, there were a couple of issues. I think I even linked off to Count the Kicks. I'll have to double check, but I remember I was like, there are resources. Like, we don't need to start over here. I mean, there was a free app. Everyone could be counting kicks right now, and being aware and making sure that you empower the parents to know, like, this is actually a potential sign of distress of the baby, or your own health could be at risk. So take it very seriously. Go in, make sure your provider also does additional testing and doesn't just brush it off as like a normal pregnancy issue. We are very much working hard on removing all of these like false statements, like baby does not run out of room and that kind of thing. But you might still be told that by your provider. So we really have to educate both the parents and the providers at the same time. So it's a joint effort with all of the organizations. And thank you all who are doing this work too. We're new kids on the block, but we're honored to work side by side with you guys and the prevention aspect. I mean, that's our goal. We don't work heavily in bereavement, but of course that always kind of comes along with it because we are bereaved parents. You know, we're all leading this based out of our love of our loss, and also, you know, the trauma just helps with grief. I think for many of us to have a place for us to feel heard and, you know, be able to take action in memory of our children, that should all be here. So thank you guys for all you're doing. And we welcome you at PUSH. If you want to volunteer as a change maker, go to pushpregnancy.org and go over there and we'll sign you up. If you want to just be on the, you know, email list and find out what we're up to, you can do that too if you're not ready to take action. But you guys are also important in this work. So thank you for everything you guys do. Just sharing, you know, social media posts, that's very important so we can spread awareness.
Yes. So thank you to everybody who joined us today. Thank you again, especially to the NICHD and to all of the courageous providers and researchers who have really taken this mission to heart. We are really, really grateful for everything that you're doing. As always, united we push. We are here to support however we can as a parent community. And as Anna was just saying, you know, if you are a parent, either a stillbirth parent or a bereaved parent or not a parent, hopefully a parent who will never experience what we've experienced, you know, we just want to remind you, your voice matters. You know, this what we watched here today is living proof that you can make a difference. And so don't hesitate to speak up when it comes to your own care. Don't hesitate to speak up when it comes to policy around healthcare and public health, or anything really. And, you know, like, just use your voice, because you can change the world. And I think we are all in this community living proof of that. So, yeah.
Thank you
all.
See you again soon.
See you soon. Take care.